Hello, my name is Mark Hobraczk. I am the Senior Manager for Policy with Hemophilia Federation of America. We're providing this short webinar for members to use as a resource in educating both patients and providers on how to best protect Medicaid enrollees from unnecessary terminations of coverage as states resume their Medicaid eligibility reviews at the upcoming end of the COVID-19 public health emergency. The public health emergency was first declared by HHS way back in January of 2020. This was a time when COVID cases first started showing up in the United States. And it's important to note that it's different from the national emergency for COVID-19 that was declared by the White House. That remains in effect. It's renewed on a yearly basis. And that deals with non-Medicare or Medicaid programs, things like FEMA, for example. The HHS PHE, by contrast, can only be extended for up to 90 days. And HHS has continuously done that throughout the pandemic. The latest extension runs until mid-January. It's expected to be the final declaration, absent some very dramatic change in COVID cases. But because HHS has promised states at least 60 days advance notice before the PHE expires, we should know by mid-November if the PHE will indeed expire in January because of that 60-day advance notice requirement. Now, the PHE, Public Health Emergency, allowed state Medicaid programs not only to get supplemental payments during the pandemic, but it also granted them significant waiver flexibilities. Things like telehealth. They could now provide services across state lines where they couldn't before. They could only provide video consultations. Now they can do audio only. So it also relaxed deadlines for COBRA continuation coverage, HIPAA, ACA marketplaces, as well as EMTALA requirements for emergency treatment and other things relating to Medicare and Medicaid. Now, the expiration of the public health emergency is a big deal because of the Families First Coronavirus Response Act. There were two major COVID relief bills that were passed by Congress early on in the pandemic, March 2020. The first of those, the CARES Act, most people are very familiar with. That's where we got our stimulus checks from. That's where the small businesses got their payroll relief. That's where the enhanced unemployment benefits came from. But the Families First Coronavirus Response Act is a really key piece of legislation for Medicaid. That's because it gave them a relatively small bump in federal matching funds, about 6%. But in exchange for that, they had to agree to what are called maintenance of effort requirements. And every state agreed to this. And it says that if they take the money, they cannot make any changes to Medicaid eligibility or benefits for the duration of the public health emergency for as long as it lasts, even if somebody is no longer Medicaid eligible. They have to remain on the Medicaid rolls for the duration of the PHE. Now, by this fall, Kaiser Family Foundation has estimated that mostly as a result of this maintenance of effort requirement, Medicaid rolls, as well as Children's Health Insurance Program enrollment, will have increased by almost 25%, a huge increase since the beginning of the pandemic. Per the Medicaid Advisory Commission, states will get about $100 billion by the end of this year in enhanced federal matching funds. That's more than twice what they spend on the higher enrollment, the 25% higher enrollment, and that will help offset the costs that they will need to spend as they are able and required to do these redeterminations once the PHE ends. Now, at that point, which we expect to be mid-January, states will have to restart eligibility reviews for their entire Medicaid populations. Nationwide, that's more than 88 million people now. So a Herculean task in some states like California or New York. Now, at the urging of those large states, CMS did agree to give them a grace period, so these wouldn't have to be done all at once or in a couple of months. They can now start redeterminations within 12 months and must have them completed within 14. Now, as a result of this, even with the grace period, we are going to see coverage losses that are an estimated 16 million enrollees by the end of the year. That's almost 20% of the entire Medicaid population. And nearly half of that amount is children, 7 million of them. Now, the other problem is that that increased federal match goes away the beginning of the quarter following the end of the PHE. So if the PHE ends as expected in mid-January, starting April 1st, states will no longer have that additional money to do these redeterminations. And that's giving them a huge incentive to do it more quickly and not really spend the time and effort needed to ensure that the data that they're using to terminate eligibility is the most accurate or up to date. And of course, a huge concern of ours is what will happen to all these terminated enrollees? Will they be able to find other coverage in the marketplace, children's health insurance program, private plans? It's especially true in states that have not yet expanded Medicaid, and there is a dozen of those. Now, HHS has been very quick to acknowledge that the impact of these coverage losses are not going to be even by any means. Now, more than half will be, as expected, people that have aged out of Medicaid during the pandemic, or they earn more money, they're no longer eligible, and they truly should not be on Medicaid any longer. However, HHS has also acknowledged, as recent as their August report, that more than 7 million of these enrollees, about 8% of the total of those 88 million, they're going to lose coverage simply due to administrative barriers, even though they are still eligible for Medicaid. And this is simply things like not returning a request for information from Medicaid timely, not having an updated address, and not getting the notice of termination of benefits and being able to appeal. For these administrative reasons, they're going to wind up being kicked off of Medicaid and have to reapply, so have a coverage and treatment interruption in between. And unfortunately, less than 3% of the people who lose coverage have any eligibility for premium subsidies in the ACA marketplaces. About 500,000 of those will fall into a coverage gap in the 12 non-expansion states we talk about. And they're not going to have any coverage options available to them that are affordable. Again, that HHS report in August recognized that a big brunt of this impact is going to be felt by so-called disadvantaged groups. People are very low income, very often minority populations, have limited access to the internet. For example, children are going to be 50% of all those who lose coverage for administrative reasons. So of that 7 million, about 3.5 million will be children. Latinos will be another 25%, and African Americans another 14%. So again, a very disparate impact depending upon the population group that you fall into. So what can be done to prepare as the end of the PHE approaches? Well, CMS has done a very good job of staying ahead of the curve. They have issued guidance repeatedly to state Medicaid programs over the last 2 years about ways to promote a continuity of coverage and to minimize erroneous terminations that may result when redeterminations are not done properly or too quickly. And so HFA, as well as our coalition partners, we're very closely following what states are doing, what plans they are putting out to mitigate against these coverage losses. Many states have already done that, and they are available on their websites, as we'll talk about. And as the PHE winds down, we're trying to use all of our available social media channels, what other educational resources we have, such as these types of webinars, to reach as many people as possible, whether that's stakeholders or Medicaid enrollees. HTCs, for example, can be very useful with their social workers in communicating with Medicaid enrollees and trying to get the word out there that this is something that will be happening very soon now, mid-January. And we've certainly encouraged other states and providers to do the same. And the CMS guidance I talked about has granted states an enormous amount of flexibility, really, in how to process these redeterminations, not just the grace period. They are giving them additional ways to verify eligibility that they didn't have access to before. This includes things like the food stamp program, the database for that, The marketplace can now share that information with Medicaid. Medicaid managed care organizations can, for the first time, provide that information. There's also allowances now to extend hearing deadlines. So for beneficiaries that didn't timely appeal a termination, they may still have an opportunity to appeal and receive a hearing on those. Now, unfortunately, even though CMS has approved over 100 waivers, 16 states still have not requested waivers. That includes really large states like Florida and New York. And so that is definitely another concern of ours. Some specific issues of concern include the fact that Medicaid, like most other private companies, have had huge staff turnover during the PHE. Up to 40% of staff, according to the National Association of Medicaid Directors. In some states, they've never handled a determination. Will they be able to do this now on a mass level? Will they have the training needed to do it? Enrollees get only a 10-day notice, believe it or not, before the benefits will be terminated. Very short period of time. So if they have not updated their address, very often their benefits will be terminated before they even know about it. So will they be able to appeal in 90 days? If they don't, what will happen? Can states even handle the number of appeals that they may get? And can states act on those within the 90 days that they're required to do so? Huge questions that need to be answered. Enrollees that are now above Medicaid income eligibility limits, obviously they're going to need help. Transitioning to other forms of coverage, will they actually enroll in CHIP or marketplace plans that require premiums or cost sharing? Big question, because according to recent studies, like one in the New England Journal of Medicine, a third of these people are actually eligible, but less than 5% enroll because of the premiums and cost sharing. So a third of those who lose coverage, eligible for the marketplace, not signing up simply because they have to pay out of pocket. And that's something that we've seen even with premiums in the Medicaid program. Nominal premiums in states like Oregon or Ohio can cause people to disenroll or not sign up for coverage. And another question, will they still be eligible for certain special enrollment periods for coverage losses or exceptional circumstances? Will those apply to them? Questions for CMS to answer. Again, repeating it because it's so important for enrollees who may have moved during the pandemic. Critically important, update your contact information with Medicaid now. Do not wait until January to do that. And there's going to be so much red tape and confusion surrounding all these new requirements. Are enrollees even going to be able to navigate through this process, especially one that can take up to 14 months to complete? Now, what happens will really vary state by state. As I mentioned before, there are a handful of states that aren't doing anything yet. There's even more that are trying to shorten this process and do it as quickly as possible because of the big incentive with the federal increased match going away in Q2. So, for example, Ohio, they're going to try to complete this process in only 90 days, believe it or not. Other states, Arkansas, Idaho, New Hampshire, 3 to 6 months. They're going to try to do redeterminations on their entire Medicaid populations. Well, they're smaller states, maybe they can do that, but then you have larger states like a Texas, for example, taking only 6 months. Missouri, Nevada, New Mexico taking up to 9 months. Again, much less than the grace period of 14 months that CMS has afforded to them. Then you have a couple states taking the opposite approach. Oregon, for example, has created a coverage option just for people that lose Medicaid after the PHE expires. They're going to temporarily bump up their Medicaid expansion program to 200% of poverty instead of just the 138% limit. So instead of $19,000 a year, people who earn up to $27,000 a year will now be able to stay on Medicaid, even if they've lost coverage once the PHE expires. Now, that's only during the grace period, during the 14 months. California, likewise, they're going to automatically enroll individuals losing Medicaid into the marketplace plans, Covered California, providing them an automatic coverage option. Massachusetts and Rhode Island are states considering a similar alternative. And there's at least 13 that are seeking CMS approval for what's called express lane eligibility. This is where they can use data from other public welfare programs like we were talking about, the food stamp program, for example. States can now rely on these different data sources to verify eligibility, including the Medicaid managed care plans we talked about. But per the CMS guidance, the information they use must be both recent and reliable. What this means is they cannot use data from an enrollee's last renewal or their initial application. The data that they use to terminate coverage once the PHE expires has to be something more recent than that. And it must be something that is considered from a reliable source, like one of these other state data sources. Now, just to provide you a couple of examples, states have created what they're calling toolkits. They're forms of different guidance documents that providers and managed care plans, HTCs, other stakeholders can use to act as what CMS is calling a trusted messenger, somebody that can be out there educating Medicaid enrollees on how to protect themselves from coverage determinations. So these packets include things like talking points, sample flyers, phone scripts, posts that they can use for their social media, examples of what to put on their Twitter feeds, for example. And you'll see them called different things like coverage ambassadors or PHE helpers, but it basically means the same thing. It's somebody that beneficiaries can look to as a trusted source of accurate information about what happens after the PHE expires. And I pulled just two examples. One is from California of the types of information that they're putting out there that you can use on social media to remind beneficiaries to update their contact information. Another is from Texas, another large state that's created both a website and a phone number like a 911. They can use 211 to go and automatically update their benefits. Again, a good source of messaging, a good simplified way that beneficiaries can get this information and respond. But by no means is it limited to these two states. There are several states doing this, including Pennsylvania, Oklahoma, Virginia, and several others. So it's good to look up the website for your respective state and see what may be available. Again, here's a couple of resources that you can certainly go to. There's many, many others. One of these links is the Texas Toolkit that I cited an example from. The other is the California Toolkit. There's also a tracker on what all 50 states are doing for the PHE unwinding. It's put out by the Georgetown Health Policy Institute, another good trusted source of information, as well as the CMS website. That's the first link for the waiver approvals, where you can see what waivers have been requested and approved relating to the public health emergency. And we certainly will make these slides available for anybody who asks, and can provide direct links to these if they don't work directly for you. Very briefly, because we get a lot of questions about SSI, wanted to touch on relationship between SSI and Medicaid and what that can mean after the PHE. For those who aren't aware, SSI, Supplemental Security Income, is one of two federal disability programs. It's the one based on your income and your assets. You have to be very low income. It's not based on your work history like SSDI. And because it's the one that's automatically linked to Medicaid, at least in 39 states, if you lose your eligibility for SSI, especially one of the common reasons is you accept unemployment in the rare situation where you could be working and still on SSI. Unemployment is unearned income. It can certainly kick you off of SSI. If you were in that situation early on in the pandemic, you would have lost your SSI, but CMS made sure that you did not lose your Medicaid through the duration of the public health emergency. That requirement remains in force, but once the PHE ends, anybody whose SSI benefits have not been reinstated will automatically lose their Medicaid at that point. So something to watch out for. Now, the Social Security Administration did come back in about a year into the pandemic and reverse course and decide that unemployment shouldn't kick you off during the pandemic. That was kind of a bad incentive. And so they said people who had been disqualified should reapply, should have been reinstated if you did that. And so your Medicaid should be continued. But if you haven't and you find yourself in that situation, please be aware that your Medicaid will end if your SSI has not been reinstated. Now, the awards and applications for SSI fell to an all-time low during the pandemic, at least 500,000 below what it had been before. Big reason for this is the obvious one. Offices were closed for a good portion of that time. A lot of people feel more comfortable applying that way for whatever reason than they do over the phone or online. And so there's a big concern that there will be a huge surge in applications now once the PHE ends. And so that can cause an enormous backlog that can also make it difficult for people to get coverage or have their treatment interrupted while they are waiting for their SSI to be approved, their Medicaid also to be approved, and their coverage to be available to them. So just to wind up, kind of summarize what we've gone over, the key points. Again, the COVID public health emergency, we fully expect it to end in the middle of January of 2023. States can start doing redeterminations 2 months before that once they get that 60-day notice. Not likely that they'll do that because they lose that federal funding right away. But even if they do, they cannot terminate anybody's coverage until the end of that month, the end of January of 2023. Now, all of those significant flexibilities that states have received during this time is going to go away, as will the pause on Medicaid termination. So those will start up right away after the PHE ends. This could result in massive coverage losses, as we've gone over, up to 16 million people. But there is that grace period of 14 months. And again, states should space that out so they do no more than 1/9 of their caseload over that time. But we know that many states won't do that because of financial incentives. And we also know many of the people that lose coverage should still be eligible for Medicaid, going to have to reapply in order to have their coverage reinstated, unless they are very vigilant about making sure that, number one, their contact information is up to date with Medicaid now, and that they timely respond to any notices for additional information that they get from Medicaid. The failure to respond to a single notice can result in an erroneous termination, so very important to do so. And that is all that I have to present. Certainly, if there are any questions, please feel free to reach out to us. My email is, you can see here on the slide. Feel free to email me directly. Feel free also to send an email to our main advocacy mailbox at advocacy@hemophiliafed.org. Again, thank you for your interest, and I hope that this information is very helpful to you and to anybody that you work with that may be on Medicaid in terms of protecting them against coverage losses at the end of the public health emergency that may be unwarranted. Thank you.